when we see patients that have really bad tooth decay and demineralization, which is the breakdown, we give them fluoride in really high concentrations to remineralize the top of the tooth. Toothpaste is in really high concentrations. And the main reason you have the labels is to prevent kids from swallowing it, because you don't want them swallowing it consistently. And most of the cases where you've seen problems with this is where you have what we call licking, where a child is consuming an inordinate amount of toothpaste. But the fact is that using these numbers like 5,000 parts, 1,000 parts, I don't want my child eating a whole toothpaste. The fact is this: the Center for Disease Control is made up annually of rotating scientists who are at the top of their field, who are competent, and every year they look at this and recommend it as safe and effective when optimally added at 0.7 parts per million to the community water. And as far as bone fractures, as far as other maladies that can happen within the bone, tell me, how many more bone fractures, what's the higher incidence in Seattle of bone fractures, of bone cancers? Kansas City, major cities that fluoridate their water. Tell me, I can tell you that the only thing that happens different in Seattle than happens in Portland is that kids get a lot less dental decay.
Okay, 1 minute rebuttal.
I don't think they've ever measured the relationship between fluorosis and fractures in the United States. This is one thing I've noticed time and time again. When you've got a very suspicious looking, very plausible, biological, harmful effect, we don't see the studies. And in terms of fluorosis, and just saying, oh, it's just cosmetic and like that, it doesn't really hurt anybody, I'm going to refer people to Jay Levy right back there, who's a dentist, who sees fluorosis every single week. And it's not just very mild or mild, you know, where you're having a hard time looking at it. He's seeing moderate fluorosis and occasionally severe fluorosis. And I keep hearing, oh, there's no severe cases of fluorosis in the United States. Even that Iowa study, the best single study in the United States, was reporting 3% cases of fluorosis. 3%. It's happening more and more. And this is Portland, where we're not even fluoridated.
Well, welcome, Dr. Levy. I'm glad you're here. I know Dr. Levy and a couple other dentists have been very vocal in their opposition to fluoride. Maybe 5. And that would constitute 5 that are against and approximately 2,995 that support it in the state, including the Oregon Dental Association, including the dental directors of all the community health clinics, safety net clinics, which I chair. I chair that. I'll be there tomorrow. We're going to talk about this subject. I see fluorosis. I see very mild fluorosis. I suspect sometimes I see fluorosis. I see a child that has fluorosis that doesn't have decay because it's microscopic fluorosis. I've seen cases of severe fluorosis, but it's actually been in Central America and other places, and I know that it happens here. I don't doubt that. I don't. But I can tell you, and I'll repeat this again, if I am looking to standards on which to base my opinion as a teacher, as a doctor, as an advocate, with all due respect, I'm not going to call Dr. Levy. I'm going to look at the CDC. I'm going to look at the American Dental Association. I'm going to look at the American Association of Public Health Dentistry. I'm going to look at every major trade and advocacy body that's respected, that has looked at this and endorses it.
Okay, 2-minute question for the pro side. What are the advantages, disadvantages of providing fluoridation individually at the home, school, or at the dentist?
You know, if providing solely individual services and solely going to individuals and providing them with toothpaste, toothbrushes, and all that, we would still have the same levels of dental care. The fact of the matter is that those individualized techniques, those individualized approaches really don't work. They're much more costly. They are much harder to implement. And the fact of the matter is that if indeed they worked, we would not be where we are. I want to address at this point, because I cannot let this just sort of stand by it. And it particularly concerns me. The question concerns me because the disparities in oral health are really important to remember. We need to remember that the Latino community and the African American community have much higher rates of dental decay. And so when we think about this individualized approaches, I'm concerned about having or creating two separate systems for those who have access to care and those who don't. And we start treating communities differently. What community water fluoridation is, at optimal fluoridation levels, is a population-based approach that benefits the entire community. This is a shared value that all four members have. This is why we are one community. This is why we are together. Therefore, I think it's important that we consider how this decision will affect not only each of us, but all of our community, and particularly those that don't have the privilege of having access to get a good oral care.
Go ahead.
You know, when I first started studying this, the thing that really stood out, as important as dental health is, that is a very, very small part of the entire story of fluoride. I just want to tell you, as far as home, school, dentist, the key word here is choice. No matter where you are, you have a choice to brush your teeth with a fluoridated toothpaste at home, or to take fluoride tablets to school, or to go to the dentist. We're fine with topical applications of fluoride. We think they can be effective, but that's for most people. There are thousands of people in Portland that have a chemical sensitivity to fluoride that cannot be exposed to. We've got one member of our leadership team. She's a doctor herself, a child psychologist. She has got a sensitivity to many, many chemicals, including fluoride. Both her dentist and her physician have told her she cannot take this. She cannot be exposed to it. We've got another member of our leadership team, young woman who has hypothyroidism, low thyroid. Okay. She knows, and there is no doubt, that fluoride lowers thyroid levels. It's the last thing you want when you have hypothyroidism. She knows, and her doctor knows, that she does not want to, she will be put at risk if she is intaking fluoridated water. When you put this chemical in the drinking water, that choice not to be exposed to a drug that can be harmful to you, that choice is taken away from you. No city council should have the right to take that choice away from you. There is no way in the world that you should be subjected to a drug in the drinking water that you can't avoid. Unless the only way you can avoid it is to buy bottled water or an expensive filter, and that is what is the real cost to low-income families.
I agree. It is about choice. It's a choice as to whether we can get past fear-based. We just heard about individuals within the organization. And believe me, I treat patients with hypo and hyperthyroidism. It's horrible. On the downside, the energy levels are horrible. They don't heal well. I mean, it's a horrible thing to have to go through. I feel for them. I care for them consistently. But I can tell you this. I also care for children every day with bombed out teeth. In my role at Care Oregon, when we want to talk about, you want to talk about choices to benefit your community, I can tell you this. 7% of the 0 to 5-year-old children in Care Oregon's health plan, which is 160,000 members, go to the hospital for their dental care. Now they're treated. That's treated decay. We treat it. We're just treating it with lots of money because we have a lot of pediatric dentists, we have 2 children's hospitals, and we're doing a whole lot of specialized care. It's very expensive, and general anesthesia is a huge risk to a young child. To follow up,
I agree, Mike. Dental access is the key to this discussion. In city after city where they've been fluoridating, it hasn't helped in the lowest income of our kids with untreated dental decay. Look at Vancouver, been fluoridating for over 30 years. In 2005, they had to create initiatives because they still had untreated dental decay in their lowest income children. Those initiatives included pediatric wellness visits targeting these kids as early as they could by their pediatricians to get them into access. In addition, look at the Tribune article this week. Dental therapists want to come to Oregon. There's a pilot study, cost-effective way to get dental access to our kids in need. However, National Dental Association lobbying against it. Those on the Hill won't train these therapists, even though there's equipment and staff already present. Surely these could help our kids that need care get care. This issue isn't about those with chemical sensitivities or those who need dental care. It's about both of those groups coming out ahead. We can be creative, we can do it here.
Okay, so next 2-minute question for the con side. How does fluoride affect those with chemical sensitivities and compromised immune systems? Can fluoride be removed from water? If so, what is the cost?
We spoke a little bit about this already. The American Academy of Environmental Medicine explains multiple chemical sensitivities as a very real and chronic medical condition. It's estimated about 10 to 15% of the population has this condition. For Portland Metro and those individuals drinking our water, that's 90,000 people. These doctors say these individuals cannot drink fluoridated water. In their position, they have said fluoride's a known neurotoxin, carcinogen, even at the levels added to public water supplies. You can only remove this with reverse osmosis. They cost about $500. You can't use a Britannia or Multi-Pure. Doesn't help for bathing or swimming. And if you force fluoridation on people who are medically unable to tolerate it, some will suffer serious health consequences. They have no way of opting out of exposure. So ask yourself, is it equitable? Is it ethical to put individuals such as Mike Lindbergh, prior city commissioner for 17 years, recommended by his MD and his internist, to avoid fluoridated water? He's in a position, as others are, where they have no way of opting out. Let's find solutions to those kids who really need help. We can do that right here. There's a new federally funded program trying to do some outreach in rural Oregon where some kids don't have dental care access. It's called First Tooth, where again, they train primary interventionists, the nurses, the nurse practitioners, the doctors, recognize these conditions. They can even do dental sealants. This is a program funded federally. And again, programs that address high risk early on, such as what they've done in Vancouver, will bring our untreated dental decay rates down. Again, both of these populations can come out ahead. Surely we can find better alternatives. This is Portland. We keep libraries open, we build parks. Where there's a will, there's a way. If this is about access, as you've indicated tonight, surely you can do more.
A few points. First, I'm on the First Tooth Advisory Council, and yes, we do all those things. We also wholeheartedly support water fluoridation. Second, I've been involved with some of the pilots you're talking about, and it's patently false to say they refuse to do it. There are complicated issues with dental education, and you're using it, and you don't know anything about it. I'm sorry, but I'm involved. I was invited to Minnesota, where the Pew Institute just about 2 months ago. I know a lot about the subject. So, when it comes to chemical sensitivity, the only thing I would say about that is there definitive evidence that Seattle, Kansas City, now San Diego, and a host of other larger cities have an epidemic of chemical sensitivity outbreak? I'd like to see the evidence. I have heartstrings. Pulling my heartstrings, the individual relationship between doctors and patients and individuals. I understand it can be a difficult situation. Show me the evidence that fluoridated communities have higher rates of any of these diseases that are being mentioned or that are being pulled from this 2006 National Academy of Sciences document. Show me anything that happens in these communities besides lowering of the rates of dental decay over the last 60 years.
We're on 1 minute. There you go. Go ahead.
Let's do the studies. I agree. There are known risk factors to this policy. The National Academy of Science study said, hey, let's do more research. We have populations of fluorosis. We can look at other risk factors such as diabetes, multiple chemical sensitivities, kidney disease, and thyroid disease. You're asking me for studies that I can't give you because the organizations that support this policy and the funding at hand has not initiated it as a priority. It's not because the science does not indicate there's risk. It's not because physicians and internists are saying, no, you may not drink fluoridated water. You have a chemical sensitivity. I would love to see studies like that when 10 to 15% of our population is affected by such diseases. In addition, and incidentally, children of color have a higher statistical indication of chemical sensitivities, most likely perhaps due to environmental exposure. Let's look at these studies.
If the question here before us is whether or not I can't remember the language you used, but the large organizations, the health industry, whatever you want to call it, if the question is whether or not the Center for Disease Control, the Office of the Surgeon General, the Institute of Medicine, and all these other organizations I've enumerated is colluding to withhold money that could lead to a better knowledge of what's hurting the American people, that's a much larger question than we can ever solve in this debate. And that's what was just suggested. I would suggest to you that the 2006 document that's quoted here, I just read you what the chair of that committee said. I would recommend you look at the 2007 follow-up. By the way, that was about a 400-page document. And I think I counted the other day somewhere around 60 words on your website, cherry-picked out of a 400-page document. And the follow-up study the next year states that they reviewed the 2006 document and still endorsed fluoride. And the same year, the Center for Disease Control looked at both and endorsed community water fluoride, as did the Surgeon General of the United States.
Okay, now we're going to move to audience questions. These questions have not been seen by either of the pro or con sides. And I wanted to thank everybody who has written these questions. It's pretty amazing how many questions have come in. They have piles and piles of 10 to 15 questions. So that's great. I really appreciate all your enthusiasm. First question. According to the CDC, only 22% of Oregonians have fluoridated water. There are 4 states with higher rates of dental decay. Texas has the worst rate of decay, and 80% of their water is fluoridated. Please explain this discrepancy. Hold your applause, please. This is for the pro side.
I'm not sure where the data is coming from. I'm not sure from the CDC. Here's what I can tell you. When you're looking at an entire population, disparities present in oral health more so than any other area of healthcare. When the child is poor, they're more susceptible to dental decay for lots of complicated reasons. So I suspect, and I haven't looked into this, that this issue with Texas having higher rates of decay with more fluoride has to do with a stratification of income levels, kids being poor. I can tell you this. If you just want to do a straight up study of a city, that's a much more stand-up comparison. Look at Seattle and Portland. That's a great example. Look at Kansas City and Portland. And what you'll see with Seattle and Portland is that Portland children have about 40% more decay than Seattle children. And there are some issues with age and the way the study is designed, but it's a good comparison. And I know the folks that have implemented most of these things they talk about in Washington. They're talking about the First Dude program, all the childhood education, all the research. Dr. Milgram, he's a friend of mine. The folks on the ground in many of these communities, up and down the I-5. I've been to these communities. I'm working on stuff in areas of Portland that models it. Of course we need those things. But if you ask anybody in Washington, in Seattle, if they think that taking water out of their community water source wouldn't have an effect on the disease rates, they'll tell you, no, you shouldn't take it, because it's the cornerstone of our comprehensive policy. And they say that in solidarity with every major scientific organization that we all look to when we want sound scientific review, including the National Academy of Sciences.
When you think of Seattle and Portland, think of apples and oranges, because they're promoting this on their website like crazy. Oh, Seattle's got such a lower rate of cavities than Portland does. Okay? Then take a look underneath the soundbite. Because what Seattle has is a much higher rate of dental sealants. Okay? Very important in preventing cavities. What Seattle also has is a healthcare system that is definitely reaching more kids at a higher rate than Portland's does. Then take a look at the study itself. The study itself in Seattle is kindergartners and third graders. In Portland, it's also third graders, but it's first and second graders. So you're comparing younger kids, kindergartners, with first and second graders. The younger the kid, the higher the rate that you may see, the lower the rate of cavities. So think apples and oranges. When you look at these city-to-city comparisons, go beneath the soundbite.
Don't think apples and oranges.
We're not done, thank you. So just so the audience knows, the use of sealants prevents dental decay, according to the CDC, by 70%. The state of Washington uses sealants, according to the CDC, about 8% more. So right away, that cuts down the statistics of dental decay. In addition, there's a higher median income, and when you look at the shortage of dentists comparing Oregon to Washington, we have a shortage of dentists in our rural areas of Oregon. In addition, Vancouver, that had been fluoridated for over 30 years, again, let me remind you, had untreated dental decay until they created new initiatives targeting those kids in need. And then those low-income kids, the untreated dental decay, went down 50% in 5 years.
I genuinely hope that the opposition is as passionate about children's oral health after this is over as they seem to be now. Because I was before and I will be after. What I can tell you is this. The sealant rate issue, that there are some discrepancies to that. One is we don't track it well. The state has a robust sealant program, and then we have Medicaid providers doing it. I'm involved with trying to get at the core of that. That 8% in Portland is actually not accurate. And I don't have the actual statistics to prove that, but we're working through it. Actually, and when you look at utilization rates for services, that is what percentage of a given age group gets care. We actually don't have much lower utilization rates. What that means is our kids are getting care. They're just getting a hell of a lot more, and a hell of a lot more in hospitals, and a lot more extractions, a lot more extensive. Whereas Seattle, they're utilizing services. They're doing a lot more preventive and diagnostic services because their teeth are strong.
Go ahead. We have 1 minute rebuttals.
Okay, sounds like you're accusing us of not caring about kids or caring about kids just for this evening. And that's just simply not true. In addition, and just to be clear, the CDC says that sealants will reduce dental decay by 70%. You're saying there's a tracking challenge with how we look at the use of sealants here. You have no way of validating that right now. What we know is 8% less of our kids here use sealants than in Washington. We're just talking about how you can't compare these cities directly. But what really matters, again, there are better alternatives. Why are we just talking about teeth? Yes, we need to improve oral health care, but yes, there are reasonable risks of this policy for other parts of our body, for our kids, their entire body. And we can come up with better solutions. We have them, we have the energy, and we have the means. Surely the National Academy of Sciences study indicated that much.
I wasn't accusing you of not caring about kids. I simply have seen in my entire career, 10 years.
Let's hold off on that. Let's move on. We have so many questions. Let's keep going. So 2 minute question for the con side. Who will guarantee that the safety of hydrofluoric acid is free of arsenic, lead, and other contaminants? Why are we using industrial waste instead of pharmaceutical grade?
Great question. Take a look at your handout. This is not data that I make up. It's on the CDC website. According to National Sanitation Foundation, 43% arsenic, 2% lead, 3% copper, and other heavy metals. It's worth noting that the EPA has no jurisdiction over these acids as water additives, only as contaminants. It's essentially self-regulated by National Sanitation Foundation, and they don't even do batch testing of their product. They test about once a year. And even that data shows this much risk to our kids. Yeah, they say it's legal, it's allowable, no big deal, more of these chemicals in other areas of our life. That's the point. Do we really knowingly want to add more of these to our public water supply when we have reasonable risk of concern as well as better alternatives? I will say again, we're intelligent in Portland, we're creative, we're passionate. Let's do something that works for everybody. In addition, consider that we haven't talked much about this tonight, just the value even of personal choice. I believe we can do more here. There's real risk. The science indicates a reasonable basis for concern. That is what we're talking about here. So when we're talking about these chemicals, and we're talking about taking them out of scrub brushes and testing them, and then giving them to cities for water fluoridation, and the CDC and supporters themselves agree, there are contaminants of these levels that you have in your handout. Shouldn't we be asking ourselves why? And pharmaceutical grade fluoride is not something that they're considering as an option. So please consider that.
First of all, I have to say, when we talk about chemicals, a lot of these names sound scary, but everything is a chemical. We have deoxyribonucleic acid in every one of our cells. We are 70% dihydrogen monoxide. But the fact of the matter is that we all have DNA and we are made up mostly water. So just because they're throwing difficult names to pronounce, they're talking about chemistry, it doesn't necessarily mean that it's all bad. Truth of the matter is that we know the science is there, that optimally fluoridated levels, this works for promoting good oral health. What we put in the water, what goes into the water, actually comes out of your water pipe at your tap water in your home as optimal fluoridated water. And measures have been done. Even in Salem, this study was done in Salem, where they measured the contaminant levels before they added fluoride, they measured the contaminant levels after they added fluoride, and there was no change. The Portland Water Bureau already reports on the levels of arsenic, on the levels of lead, and this will be clearly and obvious for everyone to look at. And I encourage you to monitor it as we move forward, and as we hopefully vote yes on 36151, and water is fluoridated in Portland, I encourage you to monitor the Water Bureau. There will be no significant change, no significant addition of any of this pollutant to your water. Let's be clear about that. So just because they're throwing out chemical names doesn't mean that the chemical reactions that occur are not actually done in a way that will optimize health benefits.